My name's Jo Gear. I'm one of the lecturers at UEA, and I'm hosting this webinar together with Roger Few. We both sit on a few groups that are really hosting and coming together for this topic today. So the Tyndall Centre, the Climate UEA group, and the Water Security Research Centre at UEA. So today this seminar focuses on inequalities of health risk. Climate change threatens to exacerbate health issues across the globe, but the impacts will not be evenly spread either between or within countries. They're likely to be experienced most acutely by those already facing poor environmental health conditions and denied access to adequate healthcare. At the start of 2020, the climate change community were hopeful that following widespread declarations of climate emergencies in 2019, the year would herald new momentum in the fight against climate change. But that was not to be. We had COVID-19 spread globally and with devastating impacts. So whilst many in the global north are calling for a green recovery from the pandemic, in the global south, COVID comes on top of the existing climate crisis. The pandemic clearly demonstrates the need for universal access to affordable and reliable water, sanitation and hygiene services, as well as more equitable access to health services. At the same time, the pandemic overlaid on the climate crisis will make it more challenging for this transition to be achieved and highlight the need for greater community and service delivery resilience to extreme weather events and other crises. So this seminar will reflect on how the COVID crisis has overlaid the climate crisis and explore how to address issues of health inequality and climate action in the post-COVID recovery. So if perhaps, Roger, if you would just like to say a brief hello, and then I will share my screen and introduce you to our panel members.
Hi folks, great to see you all here. My name is Roger Few, so I'm in the School of International Development. I'm going to sort of co-chair with Jo, but I shall mainly be monitoring the chat and inviting questions to the panelists. So yeah. Thanks,
Roger.
Onward.
Great. So, Roger, you can let me know if I successfully share the screen.
Yep. Yes,
so,
it's that.
We're lucky today to have three wonderful guest speakers. So our first one is a great friend, Batsarai Majuru, who's a technical officer with the Water, Sanitation, Hygiene and Health Unit at the World Health Organization. Her work is focused on water quality and regulation, where she manages WHO's evaluation program for water treatment technologies and coordinates a global network of water and sanitation regulators. Batsy has an academic background in environmental health and is an alumni of UEA, where she obtained her PhD. We also have Ronnie Murungu, who is an international development and humanitarian professional with, oh, I hope you can't see my little thing there, with 22 years experience spread over 14 countries. Ronnie brings substantial multi-sectoral social development experience as a leader at national and international levels. A researcher and publisher on various development themes, mostly on WASH, Ronnie is currently working with WaterAid in the capacity of Regional Programs Manager for East Africa and Ethiopia. Contributing to the empowerment and realisation of the rights of the marginalised has been for Ronnie a key driver all through his professional career and an important determinant of the type of organisations he chooses to work for. He has contributed to and has seen for himself the power of well-executed humanitarian and development programs in transforming lives, and is firmly committed to bringing about lasting change and contributing to creating a world where no one is left behind. And then last but not least, Paul Hunter is Professor of Medicine in the Norwich Medical School. Paul's key research interests include the epidemiology of emerging infectious disease, especially that linked to environmental factors, the spread of infection by drinking water, but also recreational water, contact and food, zoonotic diseases, risk assessment and risk communication, and in conducting case control and other epidemiological studies really worldwide. And of course has become very famous recently for his helpful commentaries on health issues as the COVID pandemic has affected us all. So just a little bit, I just wanted to come back and explain a little bit about how today will run, how the webinar will run. So we're going to have really a question and answer session where I'll address key questions to each panel member and they will give their response. Then I'll give an opportunity for the other panel members to comment on that question before we move on to the next question for the next key panel member. After that, we'll have a chance for the questions from the chat. So please do put them into the chat box. Perhaps if you can indicate who, if anyone, you would like to direct your question to, and Roger will facilitate that process. So I think we're ready to kick off. And my first question then, if you're ready, Batsy, is directed to you. So I'm just going to read it out from here. So from your perspective on global health, what do you think are the key challenges that the climate crisis creates for countries in the global south? For two things. So A, to improve their baseline of public health and access to health and wash services for low-income populations. And B, to interconnect with other drivers of global health inequalities, including emerging diseases such as COVID.
Thanks, Joe, for that question, and thanks also for the invitation to participate in this session. I'm glad to be here. I was saying earlier that it feels like being amongst family members, having been at UEA myself. And to come back to the question, I think you said it rightly at the beginning of this session that climate change really exacerbates challenges that have already existed in wash services and public health services in developing countries. And so the challenge that countries now face is how to mitigate or overcome the exacerbation of some of those issues that they've already been dealing with. I think the overall issue that countries are trying to overcome right now is how to maintain or accelerate progress in provision of public health services and wash services, while at the same time reacting to the impacts of climate change on that infrastructure or those services that are being put in place. And I use the word reacting quite deliberately, because I think the ideal might be that countries are working towards embedding climate resilience, for instance, in wash services. But this is actually much more difficult to achieve in practice. So, by resilience, I mean being able to anticipate, respond, cope with, or recover from some of the impacts of climate-related shocks. But in most cases, we see a more of a reactionary approach for a number of reasons. I won't claim to know all the reasons, so I'll just focus on a few, and I think those are quite common in a lot of countries. But I think these are really issues that relate primarily to policy and governance, to information and management systems, as well as financing in these countries. So just to try and unpack that a little bit, I think on policy and governance, in a lot of developing countries, low-income populations are living in mainly rural peri-urban areas. And that means that the institutions or the actors that are involved in the provision of wash services or public health services are quite varied. You have a mix of non-government actors, the government itself, sometimes the households that actually have to be, providing these services themselves. In fact, my thesis when I was at UEA was actually looking at how households were trying to provide their own wash services because that wasn't happening on the part of the government. And so essentially, there are a lot of actors that are involved, and embedding resilience in their actions, in the services that they're providing is difficult because you're having to target multiple people. What we also know now, as we're working towards a sustainable development agenda, is that regulatory oversight of services is important. So having somebody who's ensuring that the services that are being provided meet a certain level of meet a certain standard, for instance, and that they're being provided equitably. But once you have a lot of actors that are involved, it's difficult to maintain that kind of regulatory oversight. You might not have the mandate to be able to deal with private service providers or non-governmental actors, or also just by the nature and the location of where populations are. In most cases in rural areas, there is no oversight because mandates are limited to public utilities that are in the urban areas. I think the other issue that's related to policy and governance is just the politics around the provision of services. Some of the conversations that we've had, for instance, with the network of regulators that I work with, have been around, shifting focus from sewerage for sanitation, sewage services for sanitation, and something that's probably less expensive and in the context of climate change, more sustainable. And in some countries, that's actually quite unpalatable because that's perceived as receiving an inferior level of service. But the reality is also that the water resources are not able to deal with the provision of sewage services for everyone, everywhere. There's also just the politics of households themselves aspiring for something that is different. When we talk about low-income populations, some of them might be populations that have been marginalized for quite a long time. There's a history of political and historical marginalization. And so on a political level, there's this desire to bring everybody up to the same level, but it's not actually feasible with the resources that countries have and also in the light of climate change. I think the last issue on politics and governance that I would like to touch on is just to do with target setting. So we talk about, X number of countries have basic access to water services, but in terms of what level of progress is deemed reasonable, there's no clear guidance on that. Should we aim to have 20% more of our population in rural areas gaining access to water services? How feasible is that given our resources? How feasible is that given our own vulnerability to the impacts of climate change? So I think those are some of the conversations that are not being held sufficiently, in my view, to inform some of these actions that countries might be taking. I think there are also strong limitations on information systems. This mix of either having no data at all on the impacts of climate change or actually climate change in a particular setting, or having information that exists but is not being acted on. So in some countries, it's not so much that nobody has collected this data, it's this gap between data and actual action. That could be to do with political pressure, that could be to do with just not knowing where to start from. How do we prioritize some of our actions? An example that I can give, I won't name the country, but we were talking about improving water services with a link on neglected tropical diseases, recognizing that in that area, water scarcity is a big issue, but that's also related to a lot of NTDs such as trachoma, schistosomiasis, etc. But when it came to the question of, okay, where do we start from? The data to actually inform that action was not actually there. So it feels like everyone everywhere is a priority. And then that just gets you into a state of paralysis, because if everyone everywhere needs some kind of help, then yeah, it's difficult to actually act. And I think the last point that I'll mention on this is just on finance. There are financing platforms, financing mechanisms that exist, but a critical gap is how to access those finances. We already know that in a lot of countries that do need this kind of climate financing, there's a limited capacity in being able to get the accreditations that are required for it. But at the same time, a lot of the funds that are associated with development projects now have that requirement that you must include climate resilience, you must include adaptation, vulnerability and adaptation assessments as part of your projects. But unlocking that financing really requires some level of understanding of what is being required, the capacity to meet that requirement, and make sure that you're able to sustain it in the long run. So in countries where there is climate resilience being built into water systems, there's resilience being built into the public health services, it's usually being done by some external agency. And so this really brings into question the idea of, what happens thereafter when this project ends, whether it's in the next 3 or 5 years. How do we sustain some of those impacts that have been made? So I think that's, in a nutshell, my take on the first part of the question. To the second part of the question on how this interconnects with other drivers of global health risks and thinking about COVID-19, I think the real issue is that in addition to climate change exacerbating these challenges and gaps that are already outlined, it also means that countries, because they don't have that resilience, they don't have that preparedness, any emergency that comes up means essentially a diversion from any other public health programming that's been taking place. And just shifting focus to the singular issue. We know now that from the Global Progress on Malaria report, there's actually been a stall in progress, and a lot of it had to do with the fact that health workers would otherwise be going out in communities and working on malaria prevention programs had to be diverted to COVID. And the same can be said for a lot of other diseases that are out there. And so without that level of resilience that is already built into the public health systems, I see a situation in which we're continually reacting to anything that comes up because there is no, there's no background capacity to be able to absorb some of those shocks and continue with the priorities that have been set forward. But I think I'll stop here for now. Thanks.
Thank you, Betsy. Thank you for that very articulate and really informative response. Very well considered. Thank you. Ronnie or Paul, would you like to make any comment or add anything to what Betsy said?
No, I think as you said, very eloquent. I'll leave it to Ronnie to comment.
Yes, thank you very much. Yes, I think Betsy is spot on in terms of the nexus between climate change and the public health challenges that we are facing. I think one aspect that I can just add on is the issue of capacity. Currently, if you look particularly sub-Saharan Africa, there are challenges around capacity, particularly around health workers. So the coming in of climate change compounds the challenges because the governments will also need to build the capacity around how to handle and to respond to climate change as well. And this has got budgetary implications because you need to have enough budget to build the capacity of your staff to be able to handle that. But overall, I agree to the submissions that Betsy has made. Back to you.
Thanks, Ronnie. So we'll move on. So just a reminder to participants, if you have questions and you'd like to post them in the chat, please do. Roger will monitor those. But Ronnie, if I can then direct the next question to you initially. So we're being encouraged to see the COVID-19 pandemic, not just as a threat, but as an opportunity to build back better, to address some of these intersecting challenges that you and Betsy have raised, such as adaptations to climate change, improving wash services for poorly served communities, and improving public health and well-being for all. So how could building back better to reduce health inequalities be made feasible in the areas that you work in? And do you see any examples where this is already happening? Yes,
great. Thank you very much, Joe. I think let me start by appreciating you for inviting me for this special seminar. But let me also start by highlighting a brief about my organization, because the examples that I'm going to give, they also speak to the mission and also the operations of my organization. So I'm with WaterAid, and WaterAid is an international organization that has got operations in about 38 countries globally, spread in 4 continents: the Americas, Africa, Europe, and Asia. And our mandate is basically to contribute to SDG 6, which seeks to ensure that everyone everywhere has got access to quality water, sanitation, and hygiene services. So coming to your question around building back better, I will speak to about 7 aspects that we need to consider. One, I will speak around institutional and individual capacity. I would talk around innovation. I will also speak around institutional arrangements and governance issues. Then I will look into investment and financing, data and information management, aspects of inclusion, then aspects of integration, and lastly, influencing. I think just reflecting on this, I can see that there's a complementarity with what Batsi has actually submitted. I think to give more detail on the first one around institutional capacity development, we've noted that for WASH, there are a lot of capacity gaps that we are experiencing, be it at national level, at sub-national level. We are also seeing the same also at a regional level as well. And for us to be able to build back better, we need to ensure that institutional and human capacity are built. And this is further compounded. We know that the challenge is further compounded with inadequate and outdated infrastructure. So people don't have capacity, and they are also working with outdated and inadequate infrastructure. So moving forward, these are the things that we need to work on. So we note that inclusive human and institutional capacity at all levels will enable improved service provision and also will facilitate efficient operating and maintenance of technologies. If we are to look at institutional capacity development, and if I may give examples based on what we are doing as an organization and what other organizations are doing, excuse me. So as an organization, we are working with different institutions to bridge this capacity gap, but of course more needs to be done. We have a program that is called International Training Program on Sustainable WASH, which we are implementing with support from CEDA and is covering countries like Kenya, Rwanda, Uganda, and Zambia. And this program picks key personnel from different ministries, from different utilities and different organizations that have got a mandate to deliver on WASH, and trains them and also partner them with institutions that are delivering well on this. And we've seen transformation not only at individual level, but also at institution level where they are coming from, because the projects that they are working on, they are taking them back to enhance the capacity of their institutions. So through the Global Water Operators Initiative, we are also trying to partner different water utilities, be it Northern and South, and also South-South partnership. For example, we partners water utilities in Zambia with water utilities in Uganda. And these partnerships have actually helped to increase water supply, reduce non-revenue water, and actually enhance utilities performance. And one other example that I can give around institutional capacity development is the establishment of a Center of Excellence. We've managed, together with the government of Uganda, managed to establish the Water Resource Institute in Uganda, which is basically training people on different expertise around WASH. The second aspect that I can speak to around building back better is around capitalizing on innovation. We have seen and we are still seeing a lot of innovative practices, technologies being developed, and we need to leverage and scale up this innovation to ultimately lead to improved water resources and sanitation development and management. I think examples that I can give to, given the context I am operating in East Africa, a context of high urbanization, we are seeing developments and uptake of decentralized wastewater treatment system, which have actually improved the sanitation systems in high density areas. The same models have been actually taken up also in Ethiopia through an initiative which is called Small Towns, where with the government we've multiplied decentralized wastewater treatment systems. We also need to take advantage of technology, particularly the mobile system, the phones, and we have initiatives, for example, like with Viamo, where hygiene behavior messages have been deployed through the phones to reach quite a number of people. They've also gamified radio dramas on COVID and hygiene, which has helped actually to increase the reach. So as we move forward, we need to take advantage of these innovations. The third aspect is around institutional arrangements or governance systems around WASH, which we need to improve. I think one key lesson that COVID-19 has taught us is to work better collectively, collaboratively, and act with urgency. I think if we are to look at the mechanisms that are in place around COVID response, the establishment of national steering committees, which bring together different ministries with different mandates, but all collectively coming up with measures which are being deployed with agency and being followed through. Such mechanisms, I think we need to adopt moving forward. So cross-sector collaboration with clear roles, stakeholder involvement, and effective and inclusive institutions will definitely make WASH every business, and will ensure coordination mechanisms operate effectively. So we need to ensure that institutional arrangements are clear and there are clear roles to help us build back better. I think Batsi has talked around financing. I won't get much into detail on that, but in brief, the estimates from the World Bank, recent estimates suggested that achieving SDG targets for low and middle income countries requires around about 198 billion a year, that is per country. And if you look at the investments currently, we are way below that. So what needs to be done is basically to improve targeting, better utilization of existing resources, and also enhance mobilization of additional domestic and international funding to ensure that WASH is enhanced and it reaches everyone everywhere. The fourth aspect is around data and information. And I think it's very clear that there is an acknowledgement that data and information often is not available. And for that data that is available, it's not really shared. So it's very difficult for decision makers, even for program designers, to make decisions with limited data. So moving forward as part and parcel of building back better, one of the key things that we need to improve on is to improve on data collection and data management. So with regard to that, I think bringing in the experiences from my organization, we are working with governments to improve information management systems on WASH. And we have best examples coming from the government of Rwanda. We have best examples also coming from Uganda and also from Tanzania. And I think it's something that can be scaled up as well. These systems, they capture information around WASH facilities, user numbers, operation and maintenance issues, to include other variables around that. The other aspect that is also critical is around inclusion. It's a right that everyone, everywhere, irrespective of gender, age, race, political affiliation, should have access to quality WASH services. WASH is basically a health issue. It's a livelihood issue. It's also a different issue. And different needs, for example, for people with living with disability are not captured and considered in many WASH designs. So as we move forward, we need to capture this, not only for people with disability, but also for women and other vulnerable groups. But still under inclusion, we are seeing a growing shift in attention and focus from rural to urban. This is on the basis of growing urbanization. However, this doesn't mean that vulnerabilities and WASH needs are also shifting. I think those needs are still very high within the rural areas. So it's something that is coming up as a silent deprioritization of WASH in rural areas. So as we move forward, I think we need to make sure that there is a balanced act between urban programming and also rural programming around WASH service provision. But one key aspect I think that I can also highlight for as part and parcel of inclusion is around the workforce. If you look at the workforce on WASH and reflecting on a recent study that the World Bank has instituted, only 18% of the workforce in water utilities are made up of women. So there's need for the governments, private sector, different institutions to also look into this and ensure that women are employed and they take up roles within the WASH sector. To address this as an organizations, we have developed a partnership with organizations that represent interests of different groups like women, youth, people living with disability. And this has ensured that interests and also needs of different groups are captured within WASH. The second from last is around integration. Here I'm talking of integration of WASH in adaptation plans and other development sectors. I think currently WASH is not widely associated with climate change adaptation. Instead, it is being seen as a development issue. And this has implications for the prioritization of WASH in a global narrative, which is dominated by climate change. So governments need to recognize the significant threat to life, health, economic well-being that comes from overlooking the links between WASH and climate change. So as an institution, one of the key things that we have been working on with governments and also other stakeholders is to look at the inclusion of WASH within NDCs and also NDC implementation plans. And we are happy to acknowledge that we've successfully done so. In the case of government of Rwanda, they have clearly included WASH in their revised NDCs, and they have clear objectives, activities, and budgets in their NDC implementation plan. The same applies for the government of Tanzania. So I think moving forward is something that we think is critical if we are to build back better. The last aspect is around influencing. We are seeing new governments coming into place. Some, they continue to prioritize WASH. Some, they deprioritize WASH. And given a context where governments are changing, it's always important that we keep influencing on their agenda to make sure that WASH is always prioritized and is not moved from the key top list development and also climate agenda issues. So I think I can say those are my quick submissions around what can be done to build back better with regard to water sanitation and hygiene. Back to you, Joe.
Thank you so much. Again, such an articulate and informative response, really comprehensive. Thank you, Ronnie. Betsy and Paul, did you want to comment on that second question or any points raised?
Yeah, I mean, if I think the first thing is that the big thing about COVID this last year, about the mindset that COVID has generated, is that when you look back at other global public health emergencies, by and large, they were always things that were happening to them and not to us. And them can be defined in many different ways. Them can be people who live on another continent. Them can be people who live in a different part of the town that we live in. And so in the past, you know, I think the mindset of in many people perhaps was that, well, this, you know, this isn't something about me, this is something about them. And I think the big thing about COVID is that it is about us and not them. And in terms of health inequality, you know, the issue is that if a part of your town is seeing huge rapid increases in COVID, then that has direct and sometimes immediately and sometimes fatal implications for you, for what you can do, and also ultimately what you may or may not survive, and your loved ones and relatives may or may not survive because of this. And I think, and to me, this could be the thing that actually comes out, benefit that comes out of this. If you have health systems that actually just pander to the rich in your countries, if you have health systems that basically just focus on the diseases of rich people, then ultimately you can have the spread of disease and epidemics that will impact on you. And so one of the big things about COVID is that this is equally harmful, and in fact potentially even more harmful for the wealthy. You know, the older, you know, if you have the fortune to live to a great age, you are more likely to get COVID. And many people in the African subcontinent in particular don't have the fortune to live to great age. If you, through your lifestyle, are able to eat far more than you need and get somewhat obese, whilst those around you are don't have enough to eat, then you are absolutely more vulnerable. And if you look at the death rates for many diseases are always worse in the poorer countries around the world, and that is not the case in with COVID. Some of the highest death rates have been in some of the more wealthiest countries, primarily because of obesity and older age. And I think that if that generates more of an understanding that, you know, no one is safe till everyone is safe, as I think was something that the Director General of the World Health Organization said some months ago, then actually that might hopefully act as a trigger to enable more equitable distribution of healthcare resources, not only within the world as a whole, but also within our own countries. And that then leads us on to climate change. You know, it is and I think most of the people who research this sort of issue would say that ultimately the people who are going to suffer more from climate change are the least well-off countries and the least well-off sections of societies within those countries. But anything that actually negatively impacts on those countries and those sections of society has the potential to impact even on those of us. So I think if COVID has increased our sense of or has impaired our sense of invulnerability and made us realize that actually health issues can affect us all equally, then maybe there will be some good out of the epidemic. Sadly, I'm not hugely optimistic that people, once they get back to their own ways, will remember that lesson, but one can only hope. Over.
Thank you, Paul. Betsy, you had a comment in response.
I did indeed. And yeah, I fully agree with Paul's last comment there, which is sadly, while there's the awareness and recognition that COVID impacts everyone everywhere, it's no longer, you know, a limited resource country issue. It's affecting all people. I'm not sure to what extent that thinking will shape how we move forward and how we respond, or prepare and respond to future pandemics, but then also in terms of how we interact in the space of development. I think the analogy that sometimes people give is like when you see a car accident and you're driving down the motorway, you immediately check that your seatbelt is on, and for the next few weeks you always have your seatbelt. But as that memory fades, then you might, you know, not wear your seatbelt. But I guess time will tell. I wanted to pick up on the comment that Ronnie made around integration and how important it is to be integrating climate resilience into WASH programming, because I think it links to the comment that Mark shared on the chat, and he was asking, you know, whether there's some dilution of WASH with the focus on climate. And I think really this comes back to the question of framing, because to be honest, in development, there's always competition. There's always some latest kid on the block in terms of a development issue that somebody's trying to push forward. And that has a tendency to divert attention from what countries are really working on, or it might be more sexy in a way. And so I just wanted to reinforce that the real issue here is how climate change is framed, how it is integrated, like Ronnie said, into regular programming. As long as we see it as something that is separate to the provision of WASH services, then there will be competition. But if you recognize that, you know, it is integral to how we're providing these services and their sustainability, then it's easier to be including it in everything that is being done. And there are examples of countries that are already looking into that, particularly small island developing states in the Pacific will recognize that not just their infrastructure is at stake, but their actual lives. These are, you know, island countries that are at risk of being washed away, essentially. And so there's that real recognition that climate change is not an additional thing in the development agenda. It's something that we need to incorporate in everything that we are doing. But related to that, and how generally I think countries can move forward in the future, how we build back better. One point that I'd like to mention is sharing experience really matters. So whether it's experience in improving our preparedness, our information management systems, our institutional arrangements, and a lot of the work that we do now, countries will say, okay, there is guidance on this. There's guidance on climate resilient water safety planning. There's climate, guidance on vulnerability and adaptation assessments. There's so many tools that are out there. But the real question the countries have is, okay, who's actually tried this? What worked and what didn't work? Because it always boils down to your specific context, the resources that you have. And countries are looking towards each other to figure out, okay, in my region, who else has tried this? So I think in the context of climate in particular, that experience sharing is important because a lot of the risks that countries face are similar, given a particular river basin, given a particular geographical location. We saw in the example of Southern Africa, Mozambique, Zimbabwe, Malawi were all affected by Cyclone Idai. And so bringing those countries together at a regional level and encouraging that kind of peer-to-peer exchange can really kind of, move the agenda forward, because countries know at least what other people are doing and what's not working for them and what can be improved. Over.
Thank you so much. Roger, I think you were going to suggest that before we move on to Paul's question, there might be some questions in the chat, but Betsy did just answer Mark's one. Were there any others that you wanted to raise now?
Yes, I think Betsy has probably covered Mark's one, although Ronnie and Paul might also have a view on that, which is the question about whether the kind of emphasis on climate change may possibly be diverting attention from other priorities within the sector. But while you're thinking about that, if you don't mind, since there's no other questions, I've got a question and an observation, if I can. Something that Betsy said, but that also I think that Ronnie might also want to respond on. So, well, either of you, or indeed Paul as well. And you talked, Betsy, about that a lot of intervention, particularly in WASH, ends up being funded and driven perhaps by external partners, I guess, including organisations like WaterAid. And I guess that means quite often there's maybe a kind of a patchwork selective approach to it, where specific communities or specific areas get those projects. And I guess in relation to climate change, if you were able to say, okay, this area is likely to be particularly vulnerable, is that necessarily the wrong way to go about it? If there aren't the resources to stretch across an entire low-income population, is that simply the way forward, to look at particularly high vulnerable areas? Is that a sort of approach okay? Doing it in a kind of step-by-step way. So you both think about that, but let me just give my observation while you're continuing to think, which is around Build Back Better. And I think it's really interesting the way that the concept has been sort of, like many of these things, it's moved into the whole COVID recovery world. And my understanding is that it was a term that really came out through disaster risk reduction. And the essence of it is not just improving things in recovery. It's about avoiding previous mistakes. It's about avoiding replicating risk. And so the reason the word build is there is it started often with infrastructure being rebuilt back in the wrong place, or rebuilt in a way that wasn't protective against that particular flood hazard or whatever. And so it's interesting to think of it in that way, that parallels of doing things differently, which keys in with what Paul was saying about how we prioritize actions and what we do about them. We actually, it's about actually doing something qualitatively different, not just better. Even though it's Build Back Better, it's really about build back differently. So I don't know if you've got either of you or any of the three of you got any responses to my question, to Mark's question about diversion of resources through climate change, and the one about practically being selective about where spatially, geographically you focus attention, and is that okay?
So Betsy, you've got your hand up, go for it.
So I think I'd already given a response to Mark's question, so I'll let either Paul or Ronnie speak to that. But to your other question on targeting areas that are most vulnerable, I would say yes. I think any programming should be informed by some form of risk assessment, because we also recognize that the resources are not unlimited. And so it's really about targeting those people who are most at risk and making sure that they are included as part of that process. However, I think in some contexts, that is, again, an ideal. And that, if you take the example of very fragile countries where it becomes an issue of reaching the ones you can reach, not the ones who need to be reached for a variety of reasons. They're actually the most vulnerable, but they're not necessarily the ones that are being targeted in every situation. I'll also say something a little bit provocative, and I say this in my personal capacity, but I think what also happens in the development space is that when it comes to funding, the countries that are normally funding WASH programming, for instance, or anything in public health, have certain regions that they are prioritizing, maybe for political reasons, maybe because of the history that they have with those countries. And so you end up in a situation in which, for instance, there might be funds that are earmarked for a particular country or for a particular region. And that there might be other regions that actually have a much, much greater need, where the population that is vulnerable is much higher than in that setting. And so these are some of the constraints that organizations are working with in international development. But also, apart from, what donor X has as prioritized, it's also to deal with the funding, right? We're just talking about how do you unlock, for instance, the Green Climate Fund. Everybody wants to unlock those because we know that generally it's a significant part of money. And so you're trying to put some climate lens into it, whereas maybe in that particular context, that's not priority number one, but you are actually trying to access those resources. So this is just to say that the development space is imperfect in many ways, and sometimes that impacts the way in which the targeting of the people who need to be targeted is actually run. It's not to say that everything is all bad, but there are also clear examples where that is happening.
Thank you, Betsy. I wonder if we could go to Ronnie next and then Paul, if that's okay.
That's fine. Yes, thank you very much. I would like to agree with Betsy with regard to the question that Roger has asked, that it is a resource question. It is also a capacity question. And I think within the development sector, even in humanitarian sector as well, you intervene where the most need is. You intervene where the need is. Right now, for example, we have the Nyiragongo volcano, which has erupted. We have no option but to localize our intervention there because that is where the need is. But there's also a different model around that. For example, we have what is called a district-wide approach within water aid. To say, let's start with one district around enhancing wash services and scale up the best practices to other places. So I agree with Betsy that it's important. It's a resource question. It's also a capacity question that we localize our interventions where the most need is.
Thank you. And Paul, your thoughts?
Yeah, I mean, I think just going back to what I said the last time, it is, there is a selfishness element that we should also look at here, and that is, take cholera for example. We know that there are throughout Africa cholera hotspots, places where cholera seems to be able to stay on, that seems to be particularly prevalent, and to a certain extent, if the cholera had the good sense to stay in those communities, any neighboring people wouldn't have to worry about it, other than if they hopefully became altruistic. But cholera doesn't. So going back, the fact that there are cholera hotspots in Africa means that cholera stays on and has the potential to spread to in other areas and affect people who otherwise might have thought that they were relatively protected. So again, a lot of this, I think most of us on this call believe in these sort of things out of altruistic reasons. But when you are trying to convince people who perhaps are not so altruistic, the fact that it's in everybody's interests that everybody is safe for a whole raft of diseases, not just cholera, Rift Valley fever, Ebola, a wide range of other things. We saw not that many years ago, Ebola caused problems throughout much of Western Africa. And again, you know, it is, as the world gets more and more crowded, it gets more and more important for everybody's health that no hotspots stay behind, that no communities fall behind in terms of access to quality public health and services, because that ultimately could impact with devastating effect on all of us. Over.
Thanks, Paul. So I think, Roger, will move on to the third question for Paul, if you agree. Yeah. So, Paul, this is your question. At the start of the COVID-19 pandemic, there was a huge emphasis on hand washing and hygiene. And clearly people need access to water and soap in their homes, but also in their workplaces, schools, in healthcare facilities, and other public places to be able to do this sufficiently. Now that we have mass vaccination programs and also appreciate the importance of fresh air and ventilation, should we still be concerned about inequality of wash access and hygiene behaviour change? And then the second part, if I can sneak the second part in, are there key places such as countries or facilities that we should target for wash improvements going forward?
Right, well, the first thing to say, I mean, talking about hand washing and COVID, the theory behind it is the issue about what's called fomite transmission. Fomites are usually inanimate objects that you can spread an infection. The classic example of this is toilet door handles in public toilets, where, you know, you can, in theory, you can go in, open the door and pick infections up on your hand, which you then, when you suck your finger or bite your nails later on that day, you consume the leftover excrement from somebody else's hand and get sick. And we, with COVID, we felt that certainly fomite transmission was plausible and indeed probable, and has been shown for other respiratory infections such as influenza. And in the context of that, it made very good sense to push hand washing and hand hygiene as a valuable intervention. Having said that, it's actually been very difficult to prove fomite transmission for COVID during the pandemic, and you know, and I'm not aware of any really strong evidence that fomite transmission has played a major role. Inhalation transmission is largely where it's at, you know, particularly talking to somebody in the corridor face to face is without face coverings is a high risk activity, and we know that, and that is the main way of transmission. So ultimately, probably hand washing per se didn't have a dramatic impact on the spread of COVID. Now, that doesn't mean to say it's had no impact. And certainly, although we haven't been able to prove it, there will have been some fomite transmission almost convincingly. So that, you know, if you wash your hands, then you will reduce the risk to yourself, but you won't necessarily have a big impact on the pandemic. But it's not quite as easy as that, and not quite as straightforward as that. There are and this, when we move into healthcare facilities, it gets substantially more of an issue across a number of activities. The first thing to say is that when you're in hospital with COVID, COVID isn't just the only thing you need to worry about. There are all sorts of other hospital infection, methicillin-resistant Staph aureus, that can be spread by people's hands. And although in in many contexts, staff work very well when they wash their hands and they sanitize their hands in between patients and all that sort of thing. When staff are under pressure, it does get very difficult to maintain a lot of these basic hygiene practices within health systems. I mean, we saw this, you know, in my own career when I used to have a real job before I became a university professor. You know, we worked in a hospital, and we had a problem with methicillin-resistant Staph aureus on a special care baby unit, and it was a problem at a time, and it became a problem at a time when the weather was very hot, and actually as well the special care baby unit was over busy, so that the staff, they weren't feeling as perky as they normally would have done because of the intense heat during that summer, and also they had a lot of and standard slipped, and the MRSA started causing problems. And so in that context, any pressure on the health service, on a health service, you have that your access to good quality water and sanitation in those hospitals is essential, not only to protect and help deal with the primary infection, but to stop people coming in with one thing and going home and dying from something else. And we've seen this, and interesting, not a hand hygiene issue, but a hygiene issue nonetheless, with the multicolored molds, multicolored fungi that are spreading in India at the moment. The moment that people talk about three different colors, the black, the white, and the yellow. Black fungus in India is a mold. It's mucormycosis, which is not that common typically, but is being a particular problem in India at the moment in people who have got COVID. The white fungus is a candida, it's a yeast related to the, similar to the species that causes typical thrush. And we have problems when patients are on antibiotics, and particularly patients who may be undergoing radiotherapy or some other thing, often suffer very badly from thrush in their mouth, and need antifungals to control it. This seems to be happening in India with this yeast called Candida auris, which actually is resistant to most of the antifungal treatments that we have, except for the very, very expensive ones, which probably aren't going to be used in India. So that, and then the yellow fungus is aspergillosis, which is, you can get problems in the UK with aspergillosis. And the thing about aspergillosis, and the thing about the molds generally, is that they spread in less hygienic environments, dusty environments. So if you're going to keep your hospital as safe as possible, you need water to make sure things are washed down, to make sure the walls and the floors are washed so that dust doesn't build up, so that people get infected. So, and also you need water to make sure that people and staff can wash their hands when they're working between patients, so they're not spreading all these other diseases. So that actually, ultimately, although it's been difficult to prove that hand washing per se has been really important in controlling the COVID epidemic as a whole, it has undoubtedly been really important in terms of the supplies to healthcare services that enable hospitals to treat COVID patients safely and in a way that doesn't actually then give them something worse. And I think that is the I think that's a realistic issue. Now, assessment of the situation. Now, having said that, clearly, you know, we still want people to wash their hands, and don't, goodness sake, don't anybody go away and say, well, Paul said it's not important to wash your hands to protect yourself against COVID. washing your hand actually does a lot of other things than stopping you get COVID, and it probably and in that context, you know, people who don't have access to water and are aware of, for hand washing, and aware of the concerns about and real concerns about person-to-person spread through contact that hand washing would interrupt, will, I'm sure, feel, and quite rightly feel, more vulnerable from COVID, but also because all the other things. And I think one of I heard one person some months ago talking about, well, you know, whether or not hand washing protects you against COVID, you know, it would be good if this can start a habit that continues after COVID, and I think everybody would be comfortable with that. But again, going back to the key places, as you've probably gathered from what I've said so far, for me, the key places for WASH and COVID is going to be in the hospitals and the healthcare facilities. And we know that a substantial minority of healthcare facilities around the world don't have access to running water. They don't have access to improved sanitation, and they really struggle to maintain adequate hand hygiene. Excuse me. And I think if we don't address that, we are heading for a further serious problem. And I think one of the things that, talking about going back to selfishness for reasons for wanting other people to live healthier, safer lives, with healthcare facilities, one of the things about these superbugs, and you know, and it doesn't matter whether you're talking about vancomycin resistant enterococci, extended spectrum beta-lactamase organisms, often they develop in countries with low income countries for a variety of reasons, partly due to antibiotic abuse, but they then spread globally. And the way to stop them spreading globally is to improve hygiene practices in hospitals, and you're not going to around the world, and you're not going to do that unless you actually have good quality water, sanitation and hygiene in all healthcare facilities around the world. So going back to my theme of self-preservation, it is in my interest as an aging professor in the UK that ultimately a small hospital in a rural area of Kenya has adequate access to water, sanitation and hygiene, because possibly, just possibly, that is the hospital where an organism develops the resistance that would ultimately spread its way around the world and be the cause of my untimely death. And therefore, yeah, there are many reasons for that everybody should have water and sanitation access. And going back to the climate change thing here, I think one of the things that that's been difficult with WASH and climate change has been actually looking at trying to assess what is going to be the most dramatic impact of climate change on WASH availability. And personally, I have no doubt what that is. Although I can't necessarily prove it to Roger's satisfaction. But I think it's drought. And I think the impacts of drought across the world are going to be felt for many years. Not just in Europe. I mean, last time I was in South Africa, in Cape Town, and it's not that long ago, there was signs everywhere telling me not to shower and you know, be careful how much water I used because of the drought. And ultimately, when droughts happen, and they're more serious than floods, because floods, you know, the floods are more dramatic, but floods come and go, and you know, you're left with a devastated society, but you know, they're ultimately short-term events. droughts can go on for years or decades. And the accumulated impact of that on the ability to people to access sufficient water and grow their own food, and also on hospitals to provide adequate resources for maintaining hygiene and sanitation, and both of individual staff members, of patients, and of the general ward environments, will undoubtedly suffer in dustier, drier environments without inadequate water, and where the dust spreads mucormycosis, aspergillosis, which will kill people who happen to come in with severe COVID. I think I will, have I said enough now, Jo?
Thank you, Paul. That's great. That is a lot of stuff to think about. Really, really insightful and helpful. Thank you. So I guess I wanted to offer Batsy or Ronnie a chance to comment on anything that Paul has said.
Sure. So maybe just to pick up on the comment that Paul made about the links between hand hygiene and COVID transmission not being that strong, but that doesn't mean that we shouldn't be practicing hand hygiene. Doesn't mean that we shouldn't be washing our hands. I think this is true of WASH in general. Paul can equally speak to the WASH benefits and the SHINE studies that were done on fetal sanitation interventions that failed to, I guess, provide a link that was as strong as people would have liked between sanitation and health outcomes. But it would be crazy to then conclude that, oh, then sanitation is not important. So I think I just wanted to reinforce that there are a lot of direct and indirect benefits from WASH that you still get, which you can't really quantify in an exact science and say, yes, this is a figure, this is how much benefit you're going to get if you would make sure that every healthcare facility has a hand hygiene facility at the point of care. But it's still the humane thing to do. It's also the dignified thing to do, because it goes beyond just the health impacts. It's also about just the trauma of going to a health facility, either with, because you're suffering from COVID, or you're about to deliver a baby and there's no water that is there, or the toilet is so blocked you can't use it. So I think as we move forward, there are some things that should be common sense interventions, as opposed to, trying to really pin down a specific statistical figure in terms of the benefit that you're getting from it. I think it should be more of, from a point of humanity and common sense, that we implement some of these interventions. Over.
Thank you, Batsy. Ronnie, did you want to comment on anything?
Yes, yeah, thank you very much. Interesting submissions from Paul here, and I'm in agreement with his recommendation around improving WASH in healthcare facilities. Mine is coming also as a question, because one of the key things that we are seeing as a development practitioner is a key recommendation to enhance WASH services within schools. So I want to hear Paul's take around that, because that is one of the core areas where most of the development funds are being channeled to. So to hear what Paul's take is on that.
Schools are absolutely crucial, and I think one of the things about schools is that and I'm not an educator, well, other than I teach medicine, I guess, but apart from that, I'm not an expert in the theory of education by long means. But one of the things that I picked up is that actually, if you are going to get a good education, you actually need to be in school, and the long-term life impacts of not being able to be in school are quite major. And if you don't complete school, then you don't get the best jobs, you don't live in in more pleasant environments, you don't have the environments to raise your own children as well as you would have done if you had finished school and got a good job and so on. And this comes through you know, when you look at some of the impacts of water and you know, diarrheal disease in children, and how that leads to stunting and delayed educational attainment and all that sort of things, and then how that impacts on that child's future life opportunities, and how often the negative impacts of that can actually then flow not just for that child's life, but their descendants as well. And I think that is a crucial thing. And many schools, it is difficult for children to go there all the time. You know, there may not be adequate sanitation. There may be problems, particularly for girls during their periods. There may well be inadequate hand washing, and there may well be inadequate drinking water. And and certainly we did some work in Cambodia a few years ago on providing water in schools, and found that during the dry season, at least, if you were providing water in there, you had better attendance in schools than if you didn't provide safe water. And during the wet season, it was a bit different, because often these kids were kept off to help with the rice harvesting, the rice stuff. So yeah, schools are another essential part, because if we're going to change society, we've got to educate our children in general, and particularly educate our girls and our young women, so that they can help, you know, develop the society that is more inclusive and is better for public health generally. So yeah, schools, I totally agree with you, Ronnie.
Thank you, Paul. So Roger, I think, are there any particular questions in the chat that should be addressed to someone in the panel or the whole panel?
I think to the whole panel. There's another question from Mark here, who's apologised because his internet is not so good. So Mark, who's sort of overseeing running this whole seminar series, in a previous one, the point was made about knowledge, the knowledge base and the research base not being adequate enough to be able to secure funding and to build capacity. So funding from external funding. And the question, you know, was that, are there, I think you have already answered this to some extent, but are there still fundamental data gaps? I mean, and you know, your take on that, and how is it about data, or is it really about an argument and making the argument? Are there data gaps that are still acting as barriers to external investment? And if so, how to address them? So that's, if you may, yeah, if you, anyone in the panel answer that question.
So that's
see if there is not. Or actually, there's another question from Kimo. I'll also ask that while I'm here.
Okay.
So Kimo saying, Kimo Rogers, it's a shame we've not recognised the relationships between water and health at every stage of the lifespan. Perhaps availability of adequate clean water has greater potential to prolong life than adequate food. The lack of water may be contributing to the shorter lifespan in developing countries. So how could the issue of water be raised so that issues of water, so they're addressed in the short run? Kimo, having just read it out, do you want to just elaborate on that? You should be able to unmute yourself.
Yeah. Basically, yeah, because even within public health, there isn't much interaction, you know, between water and health. You know, we haven't really heightened the importance of water in health and also public health. It has been seen as a side issue most of the time. Because when we look at our public health programs, in most universities, water issues are not really addressed. You know, water shortages and issues relating water are treated separately. And that goes also for perhaps the relationship between climate and health. Yeah. So it was on the basis of that. I mean, Joe and I have had discussions, and we could take this forward. But I thought that was an important question to raise for this forum.
Okay, so I think those two questions are linked. Thank you, Kima. So over to the panel. Who wants to go first? Batsy.
Sure, I'm happy to go first. In terms of whether there are data gaps, I would say yes and no, depending on the country, depending on the context. Like I said earlier, there's some countries where we know that the data is there, and the real issue is how that data is being used. So in some countries, data is there, but it's a patchwork. So there's been no attempt to actually synthesize it into anything meaningful. There's data that's coming from that sector, another sector, or institutionally collected data versus data that's coming from external partners, and making it all make sense is kind of the missing link. But then there are also other situations where that data is not available, and I would highlight specifically in the area of financing for WASH. So in a lot of countries, the question as to how much is spent on WASH services in a given period is very difficult to answer. Financial flows into the WASH sector, how much came from external agency X, how much came from the government itself, and how much the households have been putting into these services is really, really messy. So I think that would be one area that requires improvement. It's an area that WHO works on through the global analysis and assessment for sanitation and drinking water, or GLASS. It's quite a mouthful. But anybody who goes through those GLASS reports would realize that each year the message is the same. There's some improvement, but we still need to do better to understand what's happening with this money. So that would be one area that I would highlight, that there's a critical need to better track the flows of those finances in countries. And then when you look within countries, there's also the disparity between urban and rural. Again, because in rural areas, it tends to be multiple actors, or I should say non-urban, because it could include peri-urban areas. In any non-urban area, it's pretty difficult to track, for instance, water quality, because for the reasons that I mentioned earlier, there's no regulatory oversight, there's nobody who's actually responsible for ensuring that the quality of water meets a certain standard, or operation and maintenance of the existing infrastructure. So how reliable is the water supply that's being provided in rural community X? Nobody would actually know, because they happen to be in a geographical area that does not have any oversight that's attached to it. And the same applies for sanitation systems, where there are a lot of on-site systems such as pit latrines, etc., that would not be under the purview of any institution. So I would say within countries, there are still huge gaps around what's happening in non-urban areas. And then when you look at the urban areas themselves, there is some data. It's not great, but at least we have some indication of what's happening there in terms of quality of services. Coming to the question that Kimo raised on WASH not featuring much in the health sector, I think it's essentially the health sector inherits the problems that come from the WASH sector. Doctors are not going out and building boreholes and pit latrines, etc. But if there's a problem with access to that infrastructure, with access to those services, then it shows up in the health sector. And so I think it really comes back to the idea of institutional coordination that Ronnie mentioned, that I'd also touched on earlier, that how do we get some of these sectors to be linking with each other more, and having those conversations around what's happening in the WASH sector, and what does it mean for public health in general. I would say that the issue that Paul was talking about washing healthcare facilities, in many ways has been a blessing, in that it's really opened up the conversation within the health sector about WASH, because normally when we'd be talking to ministries of health about WASH services, the needed response would be, well, this is not within my mandate. I'm not utility X that will be responsible for providing these services, or I'm not responsible for the NGOs that are drilling these boreholes. But because now we're saying, okay, this is something that is actually happening within your institutions. It's something that they're actually waking up to as ministries of health, and realizing that there needs to be that coordination with ministries of water, environment, etc. So I think as we highlight these messages and these linkages more, there's that improved awareness that WASH is actually public health 101 pretty much, and without addressing that, then there'll be very limited progress. Over.
Thanks, Betsy. That's a great answer to both of those points that were raised. I'm mindful that we're nearly at the 4:30 finishing time. It's gone so fast. It's been so interesting to hear all of you talk. I just wonder if Ronnie or Paul, if you would like to make any final comments in response to those two questions, or any other final points.
Yes, I think I can just make a comment around data and just give an example or the experience that water utilities actually faced, particularly in East Africa during the onset of lockdowns. So in May, we actually had a webinar where we brought in water utilities from Rwanda, Uganda, Kenya, Ethiopia, and basically to understand their experience, given the mandate that they were given by the government to extend water services, water supply, to formal and informal settlement. One thing that came out as a key issue was around data. There was a struggle within water utilities around how to supply enough water to informal settlements, because they were not clear, one, of the number of population, the setup and everything. So data is, for some countries, I think Kenya, they had a kind of a rough mapping in terms of expected populations in some of the settlement areas, informal settlement areas. But for other utilities and other countries, they struggled. So this is to complement what Betsy is saying, that countries are at different levels in terms of data availability, data management, and also data supply and dissemination. Thank you. Back to you, Joe.
Thanks, Ronnie. And Paul?
I'm not sure I've got anything to add to that comments from Ronnie.
Paul, I just addressed a misspell. Oh dear, terribly misspelled. Oh, come to you. So we just had a sort of an additional question around that from Annie. You know, I mean, do you think it's correct that something that WASH is neglected in healthcare facilities when they have a mandate to supply things like mop, sanitizer, cleaning products, etc.?
Yeah,
is that happening, and why? You know?
Yeah, well, I think it's always, yeah. I mean, we've had within the Global Action Plan on WASH in healthcare facilities, there's been quite a bit of talk about this over the last few years, and to me, it sort of boils down to two issues. The one is whose responsibility it is, and in many healthcare facilities, it's down to the engineer. You know, the engineer is, and the sort of the hospital medical and nursing staff don't necessarily take it on as their responsibility for it to happen. And generally, in many African countries, as indeed in many European countries, hospital managers are increasingly professional managers rather than people who have particular healthcare expertise, and whose priorities are generally more around achieving targets, particularly financial targets. And and I think often in that context, you know, that it's very difficult for them to actually understand what it is they're buying. with their limited resources, you know. And in some ways, you know, it's you can have a context. Well, the plumbing's broken and I can afford to fix the plumbing today, or I can afford to buy the antibiotics that the maternity unit desperately need, but I can't afford both. And typically it will be the antibiotics for the maternity unit that win out, to a large part because it's obvious that that would have a direct implication. No antibiotics means more women dying from puerperal sepsis. But if the reason why they're getting the puerperal infections are because they've not got good quality hygiene, because the plumbing isn't working and the nurses can't operate hygienically, then ultimately, you know, buying antibiotics is, rather than fixing the plumbing, isn't solving the problem. And I think a lot of the times people, when they come up with that sort of conflict, it's you know which is going to win out, don't you? And I think that trying to get the message across that actually probably one of the best things you can do to reduce your puerperal sepsis and maternal mortality is have a more hygienic, cleaner maternity unit, rather than desperately trying to keep the women alive who with potentially expensive antibiotics, who have got infected because it's a dirty unit. And I think that's a decision that a lot of people struggle with, particularly as, you know, you can imagine the chief of obstetrics leaping up and down in somebody's office, banging doors, thumping the table about the lack of antibiotics he's got, and trying to get that message across that actually, you know, it's probably in the long run better to fix the plumbing and provide a cleaner, more hygienic birthing experience is what's going to bring your maternal mortality rate down.
Thanks, Paul, and it's precisely what Annie's made precisely that same point in her response to as you're talking.
Gosh, we could have just read her reply.
Might have been briefer.
Yeah, it definitely would have been briefer. Yeah, absolutely.
Okay, thanks very much. Thanks, folks.
So I think we've probably come to a close. We've come to just over our 4:30. I'd just like to send a huge thanks to our guest speakers. You've been wonderful. We're so privileged to have people who can give such articulate responses to these questions. And it's clearly time to go because my dog is telling me so in the background. He's saying, Patsy, you know, Sol, he's saying enough is enough.
I could recognize that bark, yes.
So thank you so much. It's been wonderful to listen to you all, and thank you for the questions from the participants. We'll leave it there today. Thank you. Thanks, Roger.
Okay.
Thanks, folks.
Bye-bye, everybody.
Thank you.